Hello, my name is Ken Palermo, and I'm a health educator with the Missouri Department of Health and Senior Services, Bureau of HIV, STD, and Hepatitis, and I'm here today to talk to you about STIs, HIV and AIDS, and homelessness. Today's objectives include basic information about HIV and AIDS with specificity as to why they are not the same, the link between sexually transmitted infections and HIV prevalence among homeless populations, a framework for gathering STI and HIV-related information during an interview, and intervention, prevention, and care resources in Missouri. First, some information on the basics of HIV. HIV stands for Human Immunodeficiency Virus, the virus that causes AIDS. AIDS is acquired through sexual contact, HIV is acquired through sexual contact and contact with infected blood products, semen, or breast milk. HIV needs a host to replicate and survive. Research has shown the virus dies quickly outside the body, and there are no documented cases of HIV being transferred by kissing, toilet seats, doorknobs, or sneezes. HIV infection causes acquired immune deficiency syndrome. Acquired, meaning one becomes infected. Immune deficiency, meaning weaknesses in the body systems to defend against diseases. And syndrome, meaning a group of health problems that make up a disease. Left untreated, HIV wears down the body's immune system, often without the infected person's knowledge. General symptoms of HIV infection often mimic those of the common flu. As the body's immune defenses diminish, common illnesses become apparent and worsen with time. There are certain age-defining illnesses that constitute the syndrome of AIDS. HIV is still present in the body even with an AIDS diagnosis. People infected with HIV remain infectious for the rest of their lives. HIV and AIDS are not the same. As I mentioned earlier, untreated HIV reduces the body's ability to fight organisms held in check when healthy. Those basic organisms include bacteria, protozoa, fungi, and other viruses. It's important to note that an HIV diagnosis does not equate to that of AIDS. One common indicator of potential HIV infection is thrush, and this is an example of one of the basic bacteria that the body can often fight off. While the average healthy, non-immunosuppressed person can fight off an oral yeast infection such as thrush, HIV defeats the body's immune system, allowing simple bacteria to take hold. HIV risk factors, and these risk factors apply to most sexually transmitted infections also. Unprotected sex of any kind, that includes vaginal, oral, and anal. Not using a condom when having sex with a person who has HIV, or not using a condom when having sex with a person who doesn't know their HIV status. All unprotected sex with someone who has HIV contains some risk. Another risk factor is having multiple sex partners or the presence of other sexually transmitted diseases, which can increase the risk of infection during sex. And as I mentioned earlier, unprotected oral sex can be a risk for HIV transmission, but is a much lower risk than anal or vaginal sex. Other risk factors include sharing needles, syringes, rinse water, or other equipment used to prepare illicit drugs for injection. And then the last one here is being born to an infected mother, where HIV can be passed from mother to child during pregnancy, birth, or breastfeeding. Sharing intravenous drug works or needles is especially risky given the likelihood of blood contact. While HIV is a concern for intravenous drug users, hepatitis C presents an even greater risk, as hepatitis C can live on surfaces for up to 4 days, sometimes longer. Recent studies have found hepatitis C virus active and infectious in a syringe for up to 63 days. And as I said earlier, HIV can be passed during pregnancy and childbirth and has been found in breast milk. The link between STIs and HIV is significant, as CDC studies have found that those infected with STIs are 2 to 5 times more likely to acquire HIV if they're exposed to the virus through sexual contact. Generally, having an STI is indicative of the presence of risk factors, and as I mentioned earlier, the risk factors for HIV are very similar to those for the transmission of sexually transmitted infections. A current STI infection, or a current sexually transmitted infection, greatly increases susceptibility to HIV. Breaks in the genital tract lining and skin from herpes or syphilis, for example, allow open portals for HIV's entry into the body. Inflammation from chlamydia, gonorrhea, or trichomoniasis increases the concentration of cells that serve as targets for HIV. Those cells are known as CD4 cells. Proper treatment of any sexually transmitted infection is a stated HIV prevention tactic per CDC. HIV and AIDS are not specifically tracked or tracked in any uniform measure amongst Missouri's homeless population. However, given the medical and social barriers facing the homeless, their risk factors for STI or HIV infections are obvious. People who experience homelessness may be more likely to abuse substances more than the general population, engage in survival sex, engage in high-risk sex, and thus become infected with HIV or a sexually transmitted infection. Survival sex was discussed during the intersection between homelessness and domestic violence webinar done by Jennifer Carter. That webinar is available on the HMIS website under the Target Population Training link. That is a useful resource if you wish to know a bit more about survival sex and how it pertains to homelessness. And another indicator or another factor to consider in dealing with STIs or HIV amongst the homeless is that homeless HIV-positive individuals may be less likely to adhere to treatment regimens and are more likely to engage in high-risk sex. My apologies for skipping slides here. The HIV disease infection rate in 2010 in Missouri is shown on this screen. These are case rates, and meaning that calculations were conducted to determine how many rates per 100,000 in population could exist amongst Missourians. The highest age category for for potential incidence of the HIV infection is amongst those 45 to 64, and that there were 328 cases per 100,000 in population. From there, it drops down to 301 for the age range 25 to 44, and drops further in the 19 to 24-year-old age group. The rates are termed here as HIV disease. HIV disease is inclusive of an HIV infection or an AIDS diagnosis. So the two are wrapped together in determining what the rate is. The case trend of newly reported HIV cases in 2001, 18% occurred amongst those 30 to 34, and 20% occurred amongst those 35 to 49. So essentially 38% occurred amongst those in their 30s. By 2010, 24% occurred amongst those 19 to 24, and 19 amongst those 25 to 29. Essentially, the age of first diagnosis of HIV dropped a full 10 years in the 10 years between 2001 and 2010. We're not sure why this is occurring. It could be because there is an increased emphasis on screening, because as you screen, you're going to find more infection. And it's also hopeful that the reason that we're finding these numbers as far as when the first diagnosis occurs, meaning that more people are getting screened because more people are becoming educated and aware about their risk for HIV infection. In 1997, just over 7,000 people in Missouri were living with HIV disease, and again, that's either an HIV diagnosis or an AIDS diagnosis. Amongst those 7,100 living with HIV disease, there were 180 deaths. In 2008, 10,695 folks were living with HIV disease, and there were 140 deaths. And a year later, there was 11,122 living with HIV disease and 109 deaths. The death rate for HIV, or deaths attributable to HIV, are dropping as a result of increased knowledge of how to treat and how to live a healthier life with HIV infection. HIV infection is often termed a chronic disease nowadays, It's no longer what it was considered back in the late 80s, throughout the 90s, or even the early 2000s. Now for some information about the ROSI interview questions. The intake question reads as follows. Do you or a family member have HIV or AIDS? And in this situation, you need to set the medical condition under the medical tab as HIV or AIDS affected. It's important to note the definition for disability conditions, and this is a copy here of Section 223 of the Social Security Act in determining whether or not someone is disabled due to an HIV infection. Some more information on ROSI interview questions. The next intake question, are you receiving services for HIV infection? The indicators there are yes, no, don't know, or refuse to answer. It's important to note that services for HIV infection can include support, counseling, treatment, medical care, and in some instances, housing. Additionally, these services may be supplied under the Ryan White Care Funds, which is a payer of last resort administered by the State of Missouri Department of Health and Senior Services. If someone is currently receiving benefits under Ryan White Care Funds, they will be under the supervision and support of a case manager. When interviewing and asking questions about HIV infection, it's very important to stress the confidentiality regarding any responses to sexual health or STI or HIV questions. Explain that these questions are asked of everyone and that HIV status does not impact services. And knowledge of their HIV status can result in treatment services under Ryan White funding. And as I said earlier, Ryan White funding can include not only treatment, but supportive services inclusive of counseling and sometimes housing. And as I said earlier, clients should know that these questions are asked of everyone and that the responses will not impact their ability to access services. Normalizing inquiries such as these should help to lessen the stigma associated with HIV. Prior to asking about HIV status information, it might be a good idea to go ahead and explain the basics of HIV transmission and the risk factors for infection. Again, share the basics of HIV transmission, that is unprotected sex of any type, intravenous drug use, or contact with blood, semen, or breast milk from someone who is infected. Other risk factors for HIV transmission, as we said earlier, unprotected sex. Men who have sex with men, currently termed MSM, they are significantly at risk for HIV infection. Anyone who has new or multiple partners, anyone who has a history of a sexually transmitted infection, and those who partake in intravenous drug use. Lastly, those who exchange sex for housing, food, transportation, and or money are also at risk for HIV infection. One appropriate way to ask a question regarding HIV infection or exposure or risk factors is by asking, when is the last time you had sex in exchange for housing, money, food, transportation, or drugs? If the response is yes, it would be an appropriate time to ask, when was your last test for HIV? If the response is no, an appropriate response might be, when was the last time you had unprotected sex? Other options to delve into the subject of HIV exposure would be, when was the last time you had unprotected sex, as mentioned above, and again, finding out when they had their last test for HIV. If they answer no, as far as having unprotected sex, saying they did not have unprotected sex, you could offer information about where they can go to get a test for free. Based on the interviewer's assessment of the client to this point in the interview, there may be indicators of the client's involvement with survival or high-risk sex. This assessment should be considered when choosing which question to begin with. The interviewer's comfort level with these types of queries can also be considered when choosing the question to begin with. Directly questioning the client's HIV status or knowledge may not provide accurate responses. Utilizing questions that begin with when implies normalcy and acceptance on a behavioral level, as opposed to asking if the client has had a test. Additionally, a few slides ago, we mentioned that survival sex may be more likely to occur amongst those experiencing homelessness. To some degree, this question gets at that topic. If you'd like more information on survival sex, we encourage you to watch the Intersection Between Homelessness and Domestic Violence webinar available on the HMIS website. And then asking the question about when was the last test for HIV. It's important to note how HIV tests are actually administered nowadays. It could be a full blood draw, a finger stick, or an oral swab. If your client responds to this question by saying that they did have some kind of a test where a clinician or outreach worker put something resembling a toothbrush in their mouth or something with a spongy pad on the end, that was most likely a rapid test or an oral quick test for HIV. Oftentimes, when there's a full blood draw done, the test is conducted for HIV and syphilis, so that might be another way to delve into the subject. And sometimes finger sticks are also done for rapid tests, but they can also be for the test to take a little bit longer. Oral swabs almost always have results within 20 to 40 minutes, while finger sticks and blood draws can be upwards of a few days, being that that's a full blood analysis done usually by the state health lab. It's also important to note to ask if a client has said they have had a test for HIV, you should ask if they received their results, because oftentimes someone has a test conducted and they never go back to get their results. If they had the oral swab procedure, or you can determine from the interview that it was an oral swab, you can ask if they received their results, assuming that they would have gotten them within the next 20 to 40 minutes. The likelihood of them getting their results then are better since it was a quick test. But if they say they had a full blood draw or sometimes a finger stick, that may have been a test that required a few days, and you can assume they did not get their results. And asking if they got the results, responsive yes. You might want to ask if they need information on how STI or HIV is spread. And a no response would again revert back to the question about providing information on where they can get a test for free. This next screen is designed to give you hopefully a cheat sheet on how to move through the questions about HIV status, letting you know where to go as far as what their response is and determining what their status is. Some resources available to the public include takethetest.info, and when you visit this website, if you type in the zip code of the client, the system will respond with the nearest testing locations. Most locations will offer HIV tests for free, in addition to tests for sexually transmitted infections, hepatitis B, and hepatitis C. HIVtest.org is a national testing location database that will provide responses for Missouri and border states. And then there's also the website known as didyouknow.org. Education awareness information as it pertains to STIs and HIV is available at that website. Lastly, throughout the state, the Department of Health and Senior Services has what are known as disease intervention specialists. They cover the entire state, and they're experts in disease intervention, prevention, and education. They are your community specialist when it comes to STIs and HIV. They can give you resources, what's going on in the community as far as outreach events. They can also provide linkages to care agencies and organizations. So in the event that you do find a client who says that they know they are infected, but they are not participating in any type of case management or care efforts, you can reach out to your disease intervention specialist, and they can get that person into a care program. And here's some duplicate information on the disease intervention specialist. But again, these folks are out in the community, and they are ready and willing to respond to any inquiries you may have. Even basic questions about how STIs and HIV are spread, they can be the response for that. They can also provide education and awareness programs in any facility or agency throughout the state. Here's a map letting you know how to reach the DIS, or Disease Intervention Specialist, throughout the state. Those of you that work on the eastern side of the state, specifically the St. Louis County or St. Louis City area, should note that St. Louis City is administered by the state of Missouri, while St. Louis County is administered by the St. Louis County Health Department, and there are contact numbers here for each of those entities. The outlying counties from St. Louis County are covered, again, by the states, and then the regions are defined there. Ms. Leslie Whitson is the Senior Epidemiology Specialist for the Northern District, and she supervises the Disease Intervention Specialist for those areas. Kansas City is contracted also. Their contact number is there. That is administered by the Kansas City Health Department. Ms. Susan Bradshaw is the Senior Epidemiology Specialist, and she supervises the DIS assigned to the Southern Tier States. And Larry Phelan is the Senior Epidemiology Specialist for the Eastern District, and that includes St. Louis City and the ring counties around St. Louis County. Here's a list of references if you care to find where the information for this presentation is derived from. And lastly, here is my contact information. Again, my name is Ken. I'm a health educator with the Department of Health and Senior Services, and there is my email address and my direct line for any contact you may have. Feel free to contact me with any questions, concerns, or comments regarding this presentation or anything regarding sexually transmitted diseases, HIV, or hepatitis C. Thanks for viewing this presentation. Have a good day.